we've been involved in third-party reproduction for some time, and really enjoy it. It's one of our passions, and I think it kind of stemmed from just some initial patients coming to us and saying, "Hey, we need your help," and it's kind of snowballed. I've been doing these meetings here for a while and really enjoyed it. Really meeting a lot of neat people like yourselves, and as you know, it is a journey, you know. And as I talked about earlier today, you know, the way I look at this whole deal is it's kind of like it's like a stool with 3 legs, egg, sperm, and uterus. And if you kind of keep that in mind, I don't think it can be complicated because there are different ways to do it, but if you keep those 3 things in mind, I don't think it's that bad. I liken it to a Mexican restaurant with tacos, fajitas, and enchiladas. Not that much on the menu. It's not one of these Chinese menus, right? You got 88 things, and I'll take number 87 because I can't even pronounce it. So I think you can get lost in some of that in the processes. But as I also said, if you got a good clinic and you've got a really good agency, and they work well together, they'll kind of hold your hand. And so I don't know if you found that experience going on.
Yeah.
But you know, if you got both that are matching pretty well, and they're more seasoned and kind of understand it, you know, the process shouldn't be too hard. Of course, there are a lot of decisions to make. You know, who's going to be right? The surrogate, the donor. That's also kind of not an easy process, I think. And you know, I really think you guys are in charge. I'd say sometimes, you know, your surrogate agency, you know, may make it feel like, okay, you know, they really got to select you, which they do. It really needs to be a match. On the other hand, I think it is kind of the golden rule here. You are paying for it, so you should get what you want. Sometimes I find that some of the intended parents are kind of going, well, she doesn't want to do this or she doesn't want to do that. It's like, well, what do you want? I mean, you got to work together with the surrogate for sure. But if, let's say, you really want to put 2 embryos in, and she wants to put 1, then you need to find another surrogate. I don't think you should say, well, you're like a surrogate. I really would like to have twins, but she doesn't, so let's just put 1 because she wants that. And I do think you need to, and I know you're going through the matching process now. As far as the matching part, I really do think you also want to have, I don't know about similar personalities is really the word, but similar expectations. So for example, if I have an infant parent, first thing you want to do is you guys want to be comfortable with your agency in the clinic. It could be Skype, it could be visiting. We commonly do Skype, especially for our New York patients. So you can kind of get a feel, is this kind of the person I might want to be working with? And you can get additional information after the Skype, for example, financial information, references. I always encourage people to get references from the clinics they work with. And for you guys, you probably already have word of mouth, maybe some other friends that have gone through other agencies or clinic that have had good experience. Just like finding a doctor, you know, for your, I don't know, your elbow, you know. I'll ask my friends, hey, who should I go to? You know, they go, I went to so-and-so, he was great. I'm like, you know what, I trust that you had a good experience. And so a lot of word of mouth, I think, goes pretty far with all this. And so, you know, as far as the donor, you know, clinics will either have their own donors, or you can use agency donors. So if you're going to a clinic that maybe doesn't have who you're looking for, you can always use an agency donor as well. So don't feel like, you know, you look through all the donors at a clinic and you go, well, there's nobody that's really quite clicking here. Feel free to use, you know, an agency or whatever, you know. And as I talked about earlier today, you can use fresh or frozen. Frozen works very well, but you might be limited on the number of eggs, and kind of, if you figure out how much you're spending per egg, you know, if you just, for example, want 1 or 2 embryos, like if you're a single guy and you want 1 child, I think frozen eggs actually works very well. Success rates are really good with them. You tend not to have a surplus of eggs, or embryos. So for example, with frozen eggs, you might purchase, generally goes like 6 or 8 eggs. You have maybe 2 embryos to work with. And so the problem with the frozen eggs, if you, for example, have 2 embryos that we transfer, and either your surrogate miscarriage or doesn't get pregnant, then you need to purchase more eggs. And as a general rule, 2 batches of eggs probably equals just getting a donor, and just getting all the eggs she'll get. So for example, we've got donors, average number of eggs we got on our donors last year I think it was like 20.3, okay? And that usually translates to about 6 to 8 embryos. And you might say, well, oh my God, what am I going to do with all these embryos? Let's say I got my kids, but that might be an issue. But I think a worse issue is not having enough, especially if you do genetic testing. And genetic testing, and I talked about that earlier today, the pre-implantation genetic screening, on average with your donor, about 30 to 40% of your embryos will be genetically abnormal. But we do have couples that a lot of them are abnormal. They could be sperm or egg. So for example, if I've got a couple and we say, okay, we'll have Joe and Jim, we divide the eggs in half between Joe and Jim, and then we do genetic testing on the embryo. Sometimes we'll find that Joe might have 80% genetically abnormal and Jim might have 20%. So sperm does impact on that as well. And so, if you're in a situation where you have a high percentage of abnormal embryos, it's probably good to get more eggs. So in my opinion, I think more is kind of better in that situation. Any questions right now?
Can I ask about genetic testing?
You sure can.
Because that's come up. So do you generally recommend you go through that stuff in order to have a higher probability of success?
Yes, I think I do. And why do I say that? I've been involved in genetic testing of embryos for a long time. About 20 plus years ago, I was involved in the first preclinical studies, making sure it was safe in an animal model, before it went to humans. And so I've been kind of involved with the field over about 20 years. And the information we get, I think, is very valuable with respect to increasing your chances of getting pregnant, because if you put genetically normal back, you tend to have a higher pregnancy rate because the reason pregnancies don't occur is usually the embryo. Surrogates, if they're screened properly, which they will be, one of the reasons you don't get pregnant is genetically abnormal embryos, okay? It could be other factors. But these donors tend to be pretty young, so you might increase your chances of getting pregnant 3 to 5%, not huge. But I think what's also really important, what if you end up in a situation where you're doing these transfers to your surrogate and she's not getting pregnant? Then you got a situation on your hands of, is it the embryo or is it your surrogate? Then you need to start looking for another surrogate, or you need another donor. Or is it the sperm? From a clinician, that's a tough deal for us, because we get although that doesn't happen too often, occasionally happens. And so that added information can help you down the road. Now, let's say you don't do it, you put one back, you wanted one child, you're pregnant, bingo, you're fine. Also, if you do genetic testing, if you freeze embryos, you'll be just freezing genetically normal ones as well. So I'm not saying wasting your time using embryos that aren't getting pregnant, but surrogate is such a big deal. It is complex from the standpoint you've got a number of moving parts, but it's also quite expensive. And so, that could minimize, issues down the road if it doesn't work out well, and then will improve your idea of what you're freezing. And I'd say there's a fair number of my couples that do have a gender preference. It's not really the main thing here. And I think, if you take the expense out of it, and that can cost you about $5,000 extra to do the testing, between removing the cells and then doing the genetic analysis on those cells. I would say, listen, if doctors come to see me, for example, pretty quick to do it. If you're kind of in the business, I think you do it just because what you know. It's not one of those things, I'm not a car salesman, so if somebody asks me, my opinion, I might say, I think it would be reasonable to do, but I'm also not going to push it. Now, I can tell you I had a situation of a 10 of parents from Mexico, and they transferred 2 embryos, didn't do the genetic testing. One child had a problem, okay? The other one was fine. So here we are at around 12, 14 weeks. The obstetrician, I think it was in Louisville, Kentucky, said, something's not right here. And so we sent her to a doctor, actually here in New York, Mark Evans. He removed some of the cells from the placenta or the fluid, I can't remember which. And one of them had Turner syndrome, which can be a problem. And so what they did is they terminated the Turner syndrome child so the other one could survive, and she had that baby and it did fine. And I was like, I did talk to them about it. I wonder if I should have been a little more encouraging in them doing it, because in that situation, you're in a situation where you're like, oh my God, I would pay anything to get out of this mess. So I guess it's a balance. Long story short, I think it's reasonable to do that.
Are there risks to doing the testing? I get the risk of not doing it. surrogates?
Sure, very good question. So the question was, is there a risk in doing removing some of those cells from the embryo? It doesn't appear to be. You know, first babies born through that technology are about 20 now, and they keep pretty close tabs on it. So the babies being born through that technique don't seem to have a problem. Is there a problem as far as, is there a downside in removing the cells from the embryo? If there is, fairly small, and the benefits of knowing they're genetically normal outweigh that significantly. So if there is a problem, it's fairly small. So when we were more analog around 3 or 4 years ago, we can only analyze 7 to 11 of the chromosomes. It was one of those, you know, I don't think we really saw much of an improvement in pregnancy rates, if any, you know. But since we've been able to check all the chromosomes, it's gone up significantly. So I think it's a pretty powerful tool. And the way it works, you remove the cells a day before you put the embryos in, or you freeze them. So for example, if we're going through a cycle, we might, if like I was going to put embryos in tomorrow, we remove the cells today. Tomorrow we get the report card, figure out what's normal, what's abnormal, see what my couples want to do as far as putting them back, and we'll put 1 or 2 back. And as far as number of embryos, that was kind of talked about earlier. There is certainly more risk in putting back 2 than 1. Other side of the coin here with this whole surrogacy journey is if you want twins, are you going to be able to afford to do it twice and have 2 children if that's what you want? You know, when I went through the in vitro, I think we would have been nice to have twins, so we got the twins and we didn't have the worry of we're going to get pregnant again next time. And there are increased risks. The relative risks are increased, but the overall risks aren't like crazy. So if they were crazy, we wouldn't do it, you know. And we do offer an incentive program. Somebody puts 1 in, doesn't have a baby, we'll do frozen embryo change. We don't even charge them for it, because we do feel that if somebody's interested in putting 1, put 1. You can't do halves, though. Okay, guys, that doesn't work. Whole numbers. When you cut them in half, they squeal. It's horrible. Don't want to do that.
You talk about pregnancy rate. How does an 80% pregnancy rate translate to birth rate? Is it
True. So you need to know what's going on with the centers, which is a really good point. So you want to know the ongoing. So for example, even if you look at men having babies statistics, they don't, at least for us, they don't correlate with what we've got going on. What those statistics are people that, you know, gave us whatever recommendations that they get pregnant on their first or their second journey. So you're not looking at, for example, last year we did 109 cycles. It's a lot of cycles, so you get a whole lot more information. So when I looked at my information, at least from last year, we had, if we put 2 in, initial pregnancy rate was beta HCG was 84%, and ongoing has been, well, from last year was 78%. And we'll be getting some final data at the end of this year when we see everybody deliver. If we put 1 in, we're looking at a 71% chance of getting pregnant with 1, and ongoing pregnancy rate of 65%. Now, I can also tell you a lot of these are genetically analyzed embryos, and so your miscarriage rate goes down when you do the genetic analysis on these embryos, because the most common reason for miscarriages are genetically abnormal embryos. So if we have somebody that miscarriages, 60% are because of genetics, and 40% are non-genetic, meaning maybe problem with the baby's heart chamber or something like that. So,
is the denominator all told, because the gestational carrier presumably represents the best uterus you can get? Do you know what I'm saying? When you give those
they are.
rates,
Well,
that's
uterus,
all your
honestly, uterus has very little to do with anything. I'll be honest. You know, you screen them, like if you look even pregnancy rates for patients, whether they're 25 or 45, and you use donor A, whether you have a 25-year-old or 45-year-old, pregnancy rates are the same. The only difference there is the eggs. So your eggs are really and sperm can be a factor too, don't get me wrong. I gave you an example of, you know, if we split in between, sometimes we see differences. But, you know, that's the importance of getting a good donor. Occasionally you'll have a surrogate that you kind of question, you know, what's going on there. That's kind of infrequent, and the difference between what you all are doing and, let's say, another couple that are using, you know, that are, let's say, a husband and wife, and you're getting his sperm, using her eggs, putting in her uterus, is that uterus sometimes gets stimulated by the fertility medications that may or may not impact on that lining. But when you do a surrogate cycle, they're on what we call a replacement cycle of taking estrogen, progesterone. We're checking the linings, and they need to really be screened well to determine are they a good surrogate. Occasionally we get a surrogate that you go, oh my God, I love her. And I'm like, you know, her lining never really gets to be that good. I'm not so sure you should really use her. I think your chance of getting pregnant are less. So you probably shouldn't really get going on, if you're using an agency, a surrogate agency, until that surrogate is, you know, teed up and like, she's good, because there are some agencies that start the ball rolling before that occurs, but I personally would wait on that.
Would you recommend to choose someone that has like a good obstetrical history or?
Yes.
Yeah.
Yes, so
I don't
like
think so.
if I have so what the agencies do are one or two things. They will either, they'll just find the surrogate, she hasn't really been screened yet, and you know, we can go ahead and screen them and then determine. Some agencies, you know, will do some pre-screening, which there's some agencies we work with, and that's what we're doing right now, is pre-screening the surrogates. So you all don't end up getting a surrogate, you know, they're traveling to see us, and they're a dud, you know. I mean, there could be growth in the uterus, the lining might be an issue, and the obstetrical history is also important. So before I see a surrogate, I look through the history. Let me give you an example. I had a surrogate that visited us, you know, questionnaire. She said, oh, everything was perfect, you know, whatever. I look at her record. She had a blood clot when she delivered. I'm like, holy cow, you know, that's kind of pertinent. And the surrogate agency didn't even know about it, you know. And it's not to say you couldn't use that surrogate, okay? Let's say you found a surrogate and she had a problem. You know, I might say, listen, I'm not so sure about her because of these reasons. So you not necessarily would kick her out, we'd give you our recommendations. And some of the intended parents go, hey, I get it, doc, let's roll with it, okay? And if it's reasonable and she gets worked up, that's okay too. There'll be other ones where I'll say, forget it. Like, they'll say they're 170 pounds and they come in there 270. Right?
Yeah.
Like, maybe not here, you know? So that's a little unusual, or I might, you know, screen a surrogate, and although the obstetrical history is great, everything looks good, again, I'm like, you know, I'm not so sure she's really going to pay attention to what she needs to do. That actually happened a year or two ago. We had a surrogate. Didn't think she would necessarily be a very good surrogate from an instructional standpoint, doing what she's doing. Let the intended parent know, and he actually was a doctor. Not saying that doctors that, you know, all that smart, but you know, you figure you got a little knowledge there. And he's like, no, I want to roll with her. And she did screw up on some medications that did probably result in the patient having a miscarriage, and then she got kicked out of the program. You know, so not to say we're always right, and it's not just the doctor, it's the whole team. So for example, when I see surrogates, I'll ask my nurses, what'd you think of Emily? And usually we're like all thumbs up, where they go, well, I don't know. And then we communicate that with you all, because we want to make sure the best that we can, because we represent you. It's a win-win for all of us, especially you. We want you guys to be successful. Tell the surrogate, we want you to be successful, because if you're successful, you get paid, you do what you intended to do. We want the agency to be happy with the product, and of course, you know, it's our reputation. So we want everybody to be on the same playing field, and I think that's really, really important, and that's why it's really important for the agency and the clinic to work hand in hand and make sure everybody's communicating well. And we need to be communicating with you all well. When a patient comes in, we need to call you or email you, hey, we saw your surrogate, we saw your donor, everything's going great, because you also feel like, oh, what's going on? And it really doesn't matter if you're in New York or you're in Oklahoma. I mean, it's, you know, you're not going to be stopping by the clinic every day. You could. We actually had somebody from Dallas. They made, remember Michael? We just happen to be in the neighborhood. Yeah, but you're in Dallas, and this is Fort Worth. Nice to see you. It was a squeaky wheel. They got pregnant pretty quickly. So that worked. But I know it can be a little nerve-wracking for our IPs when you're at distance. But you're really looking at one visit to freeze the sperm. Some of the guys come for the actual transfer. Some do. I'd say most don't necessarily. They can. Transfer is really quick. And they usually come down for some of the obstetrical ultrasounds.